From the beginning, the value of optic disc imaging now coming from what we target for in the treatment of glaucoma. So we usually aim for lowering the intraocular pressure in order to slow the progression of glaucoma. And imaging is our tool to monitor the progression of glaucoma. So the imaging optic depth is complementary to visual field testing, as imaging usually is talking about the structure changes of glaucoma eye, while the visual field is more concerned with the function of the optic nerve. We know that the optic nerve is a variable structure. We have diameter from 2.1 to 2.8 square millimeter in patient with not high myopia, like -6 diopter refraction. And the optic is changed usually in the early years of life and be stable by the age of 10 years. And still there's significant variation according to refraction and rays. Also, when we look for the optic nerve, we know that mainly the retinal ganglion cell coursing into the optic disc are the responsible for the appearance of neuroretinal rim, and the decrease of vision is directly in relation to the loss of the ganglion cells. And the optic nerve appearance often provides evidence on presence of progression of glaucoma. So changing in the optic nerve in glaucoma are classically concerned to be cupping and pallor. However, pallor sometimes is misleading. So because the pallor of glaucomatous optic nerve usually relate to the increased visibility of the lamina criprosa, while the pallor of the neuroretinal rim usually is related to vascular insufficiency. There's some clinical signs we can detect in photography of the glaucomatous optic nerve. Some are generalized, focal, and less specific. So generalized are the large optic cup, and here we can just find that this is the difference about more than 0.2 in the cup disc ratio, and this is one of the generalized features. The more focal and more specific is the vertical elongation of the cup and the splinter hemorrhages and the nerve loss loss of nerve fiber layers. Less specific changes could be attributed to another defects or pathology like myopia, including the exposed lamina criprosa, the nasal displacement of the vessel, what's called nasal shift, and the bearing of the circumlinear vessels, and also the peripapillary atrophy. We know that we have now almost 4 common technologies for evaluation of the optic disc, including disc photography, confocal scanning laser ophthalmoscopy, and scanning laser polarimetry, and finally the widely common used the optical coherence tomography. Starting with the photography of the optic nerve, fundus photography has been primarily the method used by all ophthalmologists, started in the 20s of last century and extensively used since 60s. Single image can be used to closely evaluate the structure relationship, and it allows extended examination in a more convenient way for both the patients and the clinician. And it's not uncommon for us to find some details later on in reviewing of the photos, which is not discovered at the site of examination, especially in the hemorrhage. Photography of the optic nerve usually also allows analysis of changes over time in the anatomy of the disc with the enlargement of the cup disc ratio over time. The simple message just included the stereo disc photography has greater utility in driving size and shape of the neuroretinal rim. Common technique is just taking 2 photos with different angles, usually 15 degrees apart, and then just we can use a very primitive way to visualize stereoscopic view. It's not common nowadays because it's not available to find someone to produce this 35 millimeter film. The advantage of the optic disc photography usually, as we know, is similar to clinical exam. Better detection of disc hemorrhages, stable technology, less expensive. However, there's still disadvantage. It's mainly qualitative, depending on the experience of the ophthalmologist, not quantitative. And definitely there is inter-observer bias. And still we need high quality photographs to achieve what we need to do. We still have now 3 advanced ways of analysis of the optic nerve. High tech. They started from 90s of the last century. They are including the confocal scanning laser ophthalmoscopy, optical coherence tomography, and scanning laser polarimetry. The base of they are different. Actually, the confocal scanning laser ophthalmoscopy usually is about the optic disc tomography, while the other two ways, they are more concerned about the retinal nerve fiber layer thickness. So starting with the confocal scanning laser ophthalmoscopy, this is the concept behind Heidelberg retinal tomograph. It's had a lot of advantage and almost now used as a standard gold for the evaluation. It's a controllable depth of field, elimination of image degrading out of focus information, the ability to collect serial optional optical section. And the confocal, the idea about it is it's a beam, the diode laser, 670 nanometer, and it is focused on the X and Y haptics along the Z haptic, the length of the optic nerve in different sections. And it can produce up to 64 transaxial laser scan, depending on the depth of the cup. The surface of the cup this way and the optogram and the prepupillary retina can be calculated. And this creates a topographic map with the calculation of cup disc ratio, rim area, and other disc parameters. The second instrument is a scanning laser polarimetry, which is less in popularity. It's also using a laser with a slightly wider wavelength, and it's just depends on assessing the retardation or polarization of the reflected beam. This very common double hump map, which is a plot of retinal nerve fiber layer thickness around the optic nerve, and it's assumed that the superior and inferior poles have the greatest thickness in comparison to the nasal and temporal. The problem about scanning laser polarimetry is usually what we call the corneal effect, and it's not that accurate in patients with ocular surface disease disorders, where they are common in patients receiving already anti-glaucomatous medication, and it's also not that accurate in a patient with previous corneal surgeries like pterygium excision or a LASIK procedure. Still, they're doing now updates to avoid this kind of interference. Finally, the optic coherence tomography, which is widely used by a lot of us. It's imaging techniques started mainly for engineering purpose and now used widely in biological health issues. And it's had a lot of evolution according now what you know, we started with the time domain in the 90s of the last century, and now we reached the swept source OCT. But most of our systems now utilizing the spectral domain. So what the difference is, actually, it's about the speed and resolution. Because the time domain is much slower, we just can take about 400 A scan per second in comparison to up to 70,000 A scan per second. And now we're using swept source, which allows 100,000 A scan per second. And this gave definitely better resolutions. We have now resolution about 3 to 5 micrometer with the spectral domain, and it's clear the difference in the clarity of the photos. Also, this high speed and high resolution will allow less motion artifacts. We know how just the simple eye movement can affect the outcome of the OCT, and more data acquired for a single location, and the availability of 3D reconstruction. The analysis by CT, as we know, this is mainly around the 3 millimeter diameter around the optic nerve, and it measured the optic retinal nerve profile thickness shown in temporal, superior, nasal, inferior, and then temporal orientation. And this plot about the colors is mainly according to the normative data supplied by the machine. So it's assumed that in the patient, the green area was normal between 5th and 95th percentile, while yellow areas between first 1 and 5th percentile, and finally the abnormal is about less than 1 percentile, which is usually is not fitting for all patients, but mainly related to the normative data inside the machine. Still, there's a lot of limitation of the imaging techniques. There's a source of variability because most of our machines are depending on a fixed data about the individual desk to fovea axis. We know that the fovea usually 7 degrees below the level of the optic desk, which is not true for all patients. It's a large range. And now some machines, the confocal scan, are implementing the idea of what you call BMO. It's Bruch's membrane opening to try to standardize this data. And there's also the cyclotorsion, head tilt of the patient, and also the variable nuclear border anatomy and the optic desk dysmorphies like tilting. Also, there is what we call the floor effect. So the OCT can measure accurately in all these machines whenever the thickness is enough. So the most accurate part of the measurements will be just around the optic desk with a large thickness of the ganglion cell counts and getting less accurate towards the macula. Also, there's some confounders. If you have a patient like this patient with epiretinal membrane, even without a Bucker, this will definitely affect the ganglion cell counts analysis complex of the OCT, regardless if the patient has glaucoma or not, patient with diabetic retinopathy, on any vascular changes, and any cloudy media. So my conclusion is optic disc imaging now really advanced. Still is not a single test available allow us to detect glaucoma in all patients. In my view, imaging tests should be considered as statistical support for diagnosis and diagnostic test itself, but not a diagnostic by itself. The clinical part is very important. Glaucoma diagnosis remains still now the result of integration of clinical, functional, and imaging data. Still, this is the job of ophthalmologists, not the machines, and I believe artificial intelligence may have a big role in the near future. Thank you.